welcome everyone to the quarterly meeting of the Hampden County Health Improvement Plan Network. We are going to be starting to update the Hampden County Health Improvement Plan this year, so it's great to see a lot of people here, and I hope more will be joining us as we go along. If you haven't already, please put your name and organization in the chat and change your name on the screen with to add your pronouns in your organization. And I would like to introduce the Hampden CHIP design team. So if each of the design team members could just unmute and say hello and where you're from, go right ahead. So Brenda, why don't you start?
Sure. Good morning, everyone. My name is Brenda Evans. I use she, her pronouns. I am the Community Research Liaison in the Center for Community Health Equity Research, housed at the UMass Amherst School of Public Health. And welcome.
Thanks. Sasha?
Hi, everyone. Sasha Vians, she, her, yes pronouns, outreach manager for Planned Parenthood League of Mass.
And Benjamin?
Good morning, everyone. Benjamin Bland, Springfield Department of Health. I'm here with Mass in Motion Springfield and he, they pronouns.
Jacinta? Oh, can't hear you, Jacinta.
My mic as well, just for safety. Good morning, everyone. Jacinta Williams, she, her pronouns. I'm a land use planner with Pioneer Valley Planning Commission, and I also work with Becky.
Livana.
Good morning, everyone. Sorry, I'm having internet trouble, so I'm turning my camera off to see if that helps. I'm Livana Homestead. I'm with the Public Health Institute of Western Massachusetts. I'm the coalition building manager and part of the design team, and happy to be here.
And I don't know if Nairobi is here. Let's see Nairobi. We have Nairobi Rosa Soriano from One Holyoke is also on the design team, and Malika Jeffries from Gandara, who could not be here today. So I'm just gonna share my screen.
Hi, Becky. I'm just saying hi. I didn't get to go.
Hi, Liz. Yeah, we're just doing design team for now, but welcome. And it was great to see you in DC yesterday. Or see you on photos of you in DC. Okay. Okay, so today, we're gonna give an overview of the Hampden CHIP and plan for updating the CHIP this year, and a proposed vision statement, which I'd like everyone to look at and add to. And then we have folks from the Public Health Institute of Western Mass here to present findings from the 2022 Hampden County Community Health Needs Assessments for several hospitals in Hampden County. We also have folks here from the Holyoke Medical Center who are going to chime in, but not present today for various reasons, which they can share. And then we'll be discussing looking at priority health concerns to include in the updated CHIP. So what is a community health improvement plan? It's a broad, action-oriented strategic plan to improve the health of the community. And as a community, we think of all of Hampden County in this case. So ideally, it will include 3 to 5 priority areas with goals, objectives, and strategies and measures to address them. And it will be implemented over the next 3 to 5 years. And it will contain opportunities for partnership, leverage, and focus to enhance impact. A CHIP's created to serve community needs, respond to the results of the community assessment. So those are the CHNAs that we'll hear from later. Coordinate and align strategies between organizations and programs, harness collective resources and political will, and establish a shared framework for community health. So this is a diagram that was developed by Brittany Rosario, who's also on the design team. She's out on maternity leave. This shows what goes into developing the area CHNAs. So there's a coalition made up of hospitals and an insurer, regional consulting team and community members. That all goes into the community health needs assessments. And then those are used to, each hospital has to develop a community benefits implementation strategy. We use the CHNAs, and there's 5 or 6 in the region to develop the community health improvement plan. And then the CHIP and the CHNAs can also be used by individual organizations for their strategic planning. This year also, we're going to try to do more of integration with the process of developing the implementation strategy. So these 2 strategies will really work together a little more. And this is a diagram that shows the CHIP process. Really the focus is on community engagement throughout. So the CHNA includes, identifying stakeholders and engaging them, defining the community and collecting and analyzing data. And then the CHNA will propose some priority community health issues. We're also engaging folks in the CHIP process to also confirm the priority health issues, start to plan implementation strategies, and then actually implement the strategies. The 2017 CHIP was organized by 5 domains, which included health equity and health disparities, behavioral health, primary care, wellness and preventative care, healthy eating and active living, public safety, violence and injury prevention. The main reason for developing that plan and the goal of it was really to try to improve health outcomes in Hampden County, so that we're not last in the state according to the county health rankings by the Robert Wood Johnson Foundation. We took these 5 domains and made them into 4, really putting health equity and health disparities as an underlying foundation for all the work that we do. So this shows each of the community teams over the last couple of years has been implementing strategies from that initial CHIP. And again, improving health equity is the foundation of all the CHIP work. And then each strategy or a lot of the strategies have been pushed forward by members of the CHIP, community-based organizations, and really expanded and brought further with additional grant funds and partner coalitions. So for example, the farmers market coach, food demonstrations, HIP outreach and education. A lot of that work is also being done. The Springfield Food Policy Council and CISA partnered for the HIP outreach, but Let's Move Hampden County, working with the food bank, received a large grant from Feeding America and includes a lot of the partners and a lot of the work that was started by the community team and by Hampden County 5210. There's also a large grant from NACCHO that's working with several partners on anti-stigma campaign, and a number of other strategies have been pushed forward by other coalitions and organizations. So as we move forward, and sorry, this diagram's a little bit choppy, but we want to start thinking about, are we addressing the root causes of poor health outcomes? And how can we improve social determinants of health for long-term sustainability? So this is a tree diagram. If you haven't seen this before, the leaves of the tree represent chronic diseases and chronic health concerns, or the major health concerns. As you go down the tree to the branches and the trunk, you can start asking, but why? So for instance, under food, the food-related illnesses are diabetes, obesity, and heart disease. And so you ask, well, why is that? Poor diet, lack of exercise. Well, why is that? Is there a built environment? Is there access to food? Is there transportation to get to healthy food, or is it a food desert, which prevents people from being able to have healthy diets? And then you ask, but why there? And you get to the systems of oppression, which include racism, which may have included redlining, grocery stores not wanting to site in certain neighborhoods, and all these other underlying systems of oppression. So as we work on the CHIP, we're sort of trying to dig deeper into the work that we do and really think about what would lead to long-term change. So another way to look at this is the Robert Wood Johnson social determinants of health model, which shows that there's different health factors that affect health outcomes, and clinical care is only a small part of that. So that's one way to think about organizing the work going forward. And in fact, Franklin County has done that. So what they did was they chose 3 priority health indicators and then broke out strategies that all support those 3 indicators according to the social determinants of health. And so you don't have to work on every strategy, but it's just a nice way to organize and think about all the underlying conditions that lead to those priority health concerns. So our plan for updating the CHIP in FY23, we want to continue to build capacity and an understanding about racism as a root cause of health inequities and build a shared language. We have an implicit bias training coming up, and I will share a link to register for that in the chat. It's open to anyone who's involved with the CHIP. There's 2 one-day trainings. One's on October 27th, one's on November 3rd. And we have a limit of 40 people total. So go ahead and register for that if you'd like to take that training. We're also working on a racial equity framework for developing strategies and reviewing really what all the work that we do. We want to create a welcoming space for community, so anyone who lives, works, and plays in Hampden County to share lived experience. And stipends are available for those who are not paid by their employers. And then the goal is to really try to identify 3 to 5 priority health concerns for Hampden County. Continue to convene community teams to identify goals, objectives, and strategies. Some of these may already be in the CHIP, so we can build on those and also identify new strategies, and then develop action plans for priority strategies to implement them going forward. This is a draft vision statement, and I will share a link in the chat to a Jamboard that has this vision statement. So we'd like everyone to look at it in your own time, make comments, suggestions, even if you think it's fine the way it is. We hope everyone will take a look at that and just make sure that the CHIP, that it really says what the CHIP is all about going forward. So I can just read it here. All residents of Hampden County have an equal opportunity to pursue healthy lifestyles and to achieve social, emotional, physical, and spiritual well-being. With this vision in mind, we intend for the CHIP to provide a clear plan that empowers all who live, work, and play in Hampden County to achieve a deeper and broader understanding of the health of people living in their county and their communities, direct their own health, and access community resources to support healthy choices, engage as educated, knowledgeable participants in policy, advocacy, and decision-making activities that support the advancements of the community's health. So that's what I have for my presentation. I'm going to turn it over to folks from the Public Health Institute. So Lisa or Victoria to present results of the CHNA.
Becky, can I just jump in real quick? We had some conversation happening in the chat.
Sure.
And I think who started it in terms of just opening up the dialogue to have more conversation at some point about removing obesity from the list of poor health outcomes. And I think there's a lot of sentiment surrounding that. So I don't know when would be a good time to discuss it, but there's a lot of interest in, setting aside some time to discussing that more in depth, I think.
Okay. Yeah.
Becky, on that list, saddening to me, frankly, that Racism is not mentioned in that statement. The tree obviously needs some work, but racism is the big root. Every other ism grows out of that. It grew out once we marginalized Black folks, first stealing Indigenous land and then marginalizing Black folks, then it's easy to marginalize everyone else. And any statement that we put out in a county that is majority BIPOC people, it doesn't make any sense to me that we don't have racism in that statement.
Yes, that's a good point.
Overlay, right? Like without my reading glasses, I can't see anything. And so if we don't put this on as our equity lens, we will not be able to see it all. So I just feel like, and maybe I'm the only one, and if I'm the only one, obviously it's not a conversation, but if I'm the only one, then we obviously as a CHIP community need to do some other hard work. But
No,
just, we don't need it today. We need to think about it though.
Yes, no, and I will definitely add that. This was a sort of a last minute thing that I took an example from somewhere else, but I definitely hear you, Liz, and I will add that to the vision statement. And I'm putting in the chat now the link for the vision statement on the Jamboard. Okay.
And I would like to add, thank you, Liz, that it needs to also kind of mirror, that's not the word I want to use, but we worked so hard on the value proposition of the RAC itself. And that was one of our struggles in regards to naming what it is. And we had some pushback from some of the hospitals, but we named it. And I think we should do it here also, so as Liz suggested.
Yeah. Okay, thank you.
Great point, Brenda. And we will be talking a little bit about that RAC process as well, in case it's helpful or informative for this process.
Okay. Thanks, Lisa. Go ahead.
Great. Hi, everyone. I'm Lisa. I'm with the Public Health Institute of Western Mass. My pronouns are she, her. And I'm excited to, with my colleague, Victoria Ramos, to share a little bit high level about the community health needs assessment process. And thank you, Becky, for all that great context. That makes our job a little easier to bring people into the CHNA world. So I'm going to share the slide. Are you seeing it in presenter mode? Great.
Yes.
Okay, and I think Victoria will try to monitor chat for me when I'm talking, and then when I switch, I'll monitor chat, but also Becky, feel free. We want this to be interactive throughout the presentation. So yeah, if we miss something in the chat, feel free to just pipe up and let us know if there's a question or comment throughout. So we have done to date 8 CHNAs. 2 of them have been published, the Trinity Mercy CHNA and the Shriners CHNA, and we can share in the chat where the links to those are on the web, and those both focus on Hampden County with specific sub priorities for each. And then the CHNA for Baystate Medical Center, which also focuses on Hampden County, will be published by the weekend, fingers crossed for the Baystate folks who are putting the final touches on that. And then there also will at the same time be posted CHNAs for Franklin County, for Baystate Franklin, and then for Wing and Noble. So the Wing and Noble each include parts of Hampden County as well as other parts of the region. And then finally, there'll be a Health New England report coming later in the month, and also a Cooley-Dickinson report. So just so people have the broader regional context. Health New England will cover 5 counties, so the 4 counties of Western Mass as well as Worcester, and Cooley-Dickinson will cover primarily Hampshire County. So by November, I think we should have all of those up and on the web and available. And so the reason we are doing all of these CHNAs in concert is because in 2012, 10 years ago, 8 hospitals came together and Health New England and decided we should join forces and collaborate in the production of these. And we're excited that Berkshire Health Systems has joined recently, and Holyoke Health Systems has also started attending our meetings. And so there's the opportunity for even greater regional coordination. And a big focus is not just on collaboration across the members of this coalition, but also within community. And that great slide that you showed, Becky, that Brittany had created, I need to get a hold of that slide and put it in this presentation, but that captured it well. And so I think you've already gone over what the CHNA is, so we don't need to really belabor that point. But thank you for providing that context, and just to remind folks that it's meant to be a tool not just for the hospitals, but for communities, for organizations, to help with planning. So this is the service area. I think folks hopefully already know what region is covered, but wanted to just share the latest data on the population centers within the region. This gives more of the numbers to the community engagement slide that Brittany had shared. So we had 51 members of the Regional Advisory Council. It's actually council, not committee. I need to fix that. And some of you are here. Brenda was one of the co-chairs of this body. It met monthly and really tried to guide and drive the process. There were at least 215 people engaged through community chats, which are kind of more informal information gathering opportunities early on in the process that help inform the priority setting. And then extensive focus groups and key informant interviews, particularly around youth mental health. And we'll say more about that later. And we use this continuum that I think may come from Mass Department of Public Health, but we strive every process to get closer and closer to the power or empower end of the community engagement spectrum. You talked about the tree already, which is very helpful. We had a lot of conversations about kind of the flaws of this tree, and so I appreciated that folks were lifting up some things that they would like to see improved. I would actually love to see the flip side of this tree. You know, what would it look like if we could address all the root causes and have everybody thriving and have positive health outcomes? So I think there's a real interest in having a tree that looks at what the world we would have if, in fact, we achieve our goals. So Brenda had alluded to the Regional Advisory Committee. I know this is a lot of text here, but the Regional Advisory Council created a value proposition, so guiding values for the process. And the part that I highlighted, says, for the CHNA, we will engage in an inclusive, transparent, people-centered, and community-engaged process that recognizes community assets, is informed by history, and addresses white supremacy ideologies, structural and institutional racism, and other forms of discrimination, such as sexism, homophobia, ageism, ableism, immigration status, anti-Semitism, etc. We could add transphobia to that. There's other isms, and this list is not meant to be exhaustive. So in the end, we were not able to put this value proposition directly into the reports. So we created guiding principles that the coalition members and the RAC could all agree on. And those guiding principles are in every report. And they talk about the causes of inequity being deep-rooted, longstanding belief systems and narratives that confer advantage and power to certain groups and have historically and continue to, in order to disadvantage and disempower other groups. And we name the specific groups in the guiding principles. We talk about systemic racism, structural poverty, and the other isms perpetuating dominant advantage in public policies, institutional practices, healthcare systems, and individual actions. And we talk about the fact that as a result, one's race, ethnicity, age, gender, wealth and income, disability status, and other attributes, because of these dominant systems of oppression, determine one's ability to receive quality healthcare, earn a living wage, live in safe housing, and so forth. So I would love Brenda or anybody else who was part of the Regional Advisory Council, if you want to just share any reflections on this, how we got to this point and why it's important to lift this up relative to the CHNA.
Thank you, Lisa. There was a question in the chat. Benjamin, were you referring to why this value proposition was not included in the reports?
Yes, correct.
We had a lot of pushback from the powers that be on the hospital end. They felt very uncomfortable. I think a lot of board members of those institutions felt very uncomfortable using the words white supremacy, structural and institutional racism. In my personal opinion, it was white fragility. And it was a struggle. It was a struggle.
Thank you. I appreciate that.
But as a RAC, we adapted this value proposition. Liz, you had a question?
Well, I want to have a little more clarity on the role of the RAC versus the role of board members of hospitals who do not represent the people who are illuminated in a community health needs assessment. And I want to congratulate Lisa. I worked for the Public Health Institute, their friend, your friend. This is the most beautiful writing that has come out since, period. Like yesterday at the White House Conference on Hunger and Nutrition, this is what we were encouraged by every key leader to do. And I think it's magnificent. And I want to know what we do as community members. Because, so I run these organizations and whatever that means, blah, blah, blah. But I am Black and poor and live in Mason Square. And everything that you're saying is my life story. And so for them to, you're helping them to understand that they're denying us. Like, prove to me why this isn't accurate. Don't talk to me about your discomfort, because it's exactly that. It's exactly white fragility. And white people need to be bold and brave, especially those who control the resources. I'm not suggesting that, many of you have amazing civic muscle, but are we just supposed to say, okay, is really my question. Do we have any recourse?
Yeah, Gail, do you want to weigh in as well? Gail, I don't know if you're going to directly address Liz's point, but Gail is also a member of the RAC.
Great, thanks, Lisa. Thanks, Liz and Brenda, for your comments. Just for those who don't know me, I'm Gail Grammarosa. I work for the town of Ware. I manage the Quabog Hills Substance Use Alliance, but also I am the co-chair of the Baystate Wing Hospital Community Benefits Advisory Council. And I served on the RAC for this year's Community Health Needs Assessment. I share the concern that Baystate hospitals in particular were reluctant to adopt this language. I had conversations with my fellow Community Benefits Advisory Council members. I had conversations with the president of Baystate Wing Hospital at the time. She was supportive, but she was not the final decision maker. As one of our fellow RAC members is often very helpful to remind us, these are both institutions, but they're made up of people. So there were specific people at the highest levels of leadership for each of the Baystate hospitals, and then what I sometimes call conglomerate Baystate, like the whole Baystate system has senior individual leaders at the board of trustees level. I had conversations with Baystate staff who also were very disappointed that even their in-house advocacy for Baystate to adopt this language and have it be in the CHNA reports did not happen. I think we were all disappointed. I guess one thing I would just add is that as a result of these difficult conversations and a result of some of this language from my perspective being inappropriately watered down, ultimately what's going to show up in some of the Baystate reports is not exactly this language. It prompted us to say, a group of us from the RAC want to keep talking, want to keep meeting, want to see how we can both externally and internally make headway within at least the Baystate system. My last comment is, all hospitals have mechanisms by which community members need to register when there's a concern or a complaint or something where your needs are not being met. Legally, they are charged with meeting community needs. That's what community benefits is all about. And I think, any of the hospitals who were squeamish about this language need to hear from community members.
Thank you. Thank you, all three of you. And I just want to, in fairness, say it was not only Baystate, there were other institutions that were challenged, particularly by the white supremacy ideology. That really, I think, was the kind of perhaps not surprisingly pivotal phrase that that caused them to take pause. And I totally appreciate and understand the frustrations that particular value proposition did not end up in the reports. And, this is a process, it's a journey. And what did end up in the reports, the guiding principles, is way stronger than what was in the reports 3 years ago. So we're not there yet. The journey continues and we are making progress. So I know that might be small consolation.
No, it's no consolation. But I want to convey my deep respect and appreciation for the RAC putting this out and encourage us as a CHIP to think about how we use this statement. And I want to say, I've been waiting 500 years. And it is not a consolation. And if the president of the United States can stand up in front of a country that may have 40% people who would re-elect someone who is clearly a white supremacist leader, and we can't be brave enough, they need to go take their happy behinds down to their emergency rooms and see who's sitting in those hospitals. And I recognize in some of the outside of Springfield that may look different. But everything that happens to poor white people now happens because they honed it on poor people of color. And if they looked around the room at each other when they were experiencing their discomfort, they would see that they were all white. That should make them uncomfortable. So I'm preaching to the choir, and I'm going to think really strategically around this is what I'll say, because I sit on the advisory council for the Health Policy Commission. And this is exactly the conversation that the tables, your board members, those board members don't get invited to, where people at Mass General and others are having this kind of hard conversation. So if we want to be cowards, then let's be cowards, but tell the truth about it. That's all I'm saying. Mm-hmm. And this shows you how much work we have to do. So even if we can't get a decent statement, we can at least make sure we're doing decent work. But again, I think this is brilliant, and I would love to have it to print, to hang everywhere, because this is exactly what needs to be said. And I don't want you to feel like your hard efforts around this were wasted, because they were not. I don't blow smoke and I don't give false flattery, and this makes me sit up stronger, makes my core feel stronger. Like that's where this work is, right here. I could do all the HIP education I want, but if we can't name it, it's useless. Thanks, Becky, and everybody else.
Thank you. And Jacinta?
Hi, I'm new to this conversation as I'm beginning to work with Becky. So I'm just going to ask this question just as me, as a person, and listening and observing everyone and what they're sharing. Lisa, and I guess Gail as well, I'm wondering if when you're having these conversations to try to include this language, if there is a way, and I'm thinking in terms of how certain demographics respond to certain things. So in terms of receiving or being receptive to information, some people love to have data thrown at them and they want numbers and they want figures. So I'm wondering if they're sort of wanting to dispel or maybe dispense with this language because it makes them uncomfortable. If we can't somehow introduce into the argument all the facts and figures surrounding hospital records and things that have to do with eugenics and the long history of eugenics in the medical community, and that sort of how it's played a role in shaping the medical community and how they view people of color and their bodies and how they treat them when they go to the doctor and when they go to the hospital. Because I think that's relevant. It's very relevant. So if we can introduce that into the conversation, if we can bring in that element and say the United States has a long history of basically experimenting on people of color, both domestically and abroad, and start bringing that into the conversation, I feel like it would be a lot more difficult for someone to simply say, I don't like the word white supremacy. It's like, well, here it is in data form for you. Here are the facts, here are the figures, here are the pictures. I think that might be a way to go, because you can't refute that ideology still exists and plays a role in how people are seen and treated today when they go to, a doctor or get treatment in the hospital. So that's all I would add to that.
Yeah, I mean, I think that's an excellent point. Thank you. And I think to Gail's point, we need to, and Liz's point, we need to keep advocating in all the spaces we can with the hospitals and figure out how to get to the leadership and have them engage in the conversation, because the staff who were part of the RAC were totally on board and supported this language, and they can do their best to advocate internally, but ultimately, it needs to be directly with hospital leadership to engage in these conversations. We're going to try to tell as much of the RAC story as we can as a way to help keep the conversation going. Risa.
I was just wondering, it seems like a perfect opportunity to have an in-person meeting with the hospital leadership. Like you all, I don't come to these meetings that much, but all this great work and everything you're saying, it seems like the following up or like, well, white people, we also could speak up, and say, this is a huge gap. It's 21st century. Like, this is insane that they couldn't put this. I mean, it is shocking that they couldn't put it in. So anyway, just a suggestion of like follow-up activities that are more proactive. I'd be up for that.
Just to play a little devil's advocate with myself and y'all, some of y'all weren't happy when I started talking about white supremacy some years ago. So we don't want to make anyone into the good white people and the bad white people. It is a journey, and my frustration of I'm tired of waiting 500 years is very real, but let's not pretend that we as a CHIP got here that easily either. We have all grown, exponentially. So I'm not trying to cut old rich white guys too much slack, and maybe the occasional woman thrown in, but I'm also really aware I do live in the real world, and some of y'all looked at me like I was crazy not that many years ago when I started talking about white supremacy and naming it. And but that shows how we have to be like an unrelenting drip, because I pulled back when I realized people were getting super scared, but I never stopped. And so that's what I think we have to do, is never stop. And those of us who have the levity to do it in their own organizations, being able to adopt some of this language ourselves. Lisa, I don't know if this can be shared informally, but I'll just start talking it. Sometimes that's just what we have to do. We have to work like 6 trains running at the same time.
Yeah.
And some of those people are older, and they will someday go sit in the country somewhere.
Yep. Okay, let's hear from Brenda and then let's, if it's okay with folks, move on so we can get to some of the findings. I think this has been a really important conversation. I'm glad it's spurring some thoughts about how we can follow up with it.
I just wanted to speak to Jacinta's point in regards to data. Hospitals do get this information. They do get disaggregated data on different populations and what their health outcomes are. Now, what they do with that information, like for example, say a hospital noticed within their data sets that they are not reaching Black men with hypertension. That's an issue. Now, what they do with that information, who knows? They might do some internal programming, they might do some internal whatever, but they do have, the bottom line is they have that information. Thank you, Lisa.
Thank you, Brenda. All right, so really appreciate all of your thoughtful sharing around this and trying to help us keep our feet to the fire of not dropping this now that CHNAs are going to be published and we have 3 years between now and the next one. So through all those difficult conversations, we did try to move closer to the kind of community-driven end of the spectrum of community engagement. We did refine those equity values, and it was a difficult process. And we got to a better place than we've been to before, and we have so much more to do. There was a shared commitment to work on one particular issue, which is youth mental health, and I'll share more about that. And then we did try to make the CHNA reports more accessible and actionable. And I will say personally, as the person who had the vision for that, but then the reality of just drowning in so much data is that we fell short in that. And there's still very long reports. And there's not as much that we would have liked to have included around, for example, policy opportunities related to these issues. So we have more to do in that regard. That said, Baystate at least will be creating short, very visually appealing, sort of at a glance that documents freestanding that will be maybe 4 to 6 pages, and those will be translated into several languages for each hospital. So at least there will be something that is more accessible for community members. So I think that Becky kind of described the process, but basically we look at the 2019 reports, we try to figure out what has changed, what the most pressing needs are. And then as Becky noted, this goes into, it feeds into a lot of different planning processes. So this time around, what was different was a couple of things. One is we did have the coalition choose one regional priority for shared investment of research resources and for coordinated action, and they chose youth mental health. So every report has a major section on youth mental health, and then each hospital was allowed to choose up to 3 priority issues in addition to youth mental health, as well as a couple of priority populations. And there was a lot of overlap among the different hospitals in what issues they chose. And so we've highlighted some of the ones that were a particular focus for Baystate Medical, but also for some of the other hospitals. Luckily, these aligned somewhat well with the CHIP priorities from the past several years. So we've been able to discuss the results in alignment with those priorities. So obviously COVID-19 was a huge factor in community health, and that also is, each report has a section devoted to COVID-19 and its impacts, and also in other sections, we talk about the impact of COVID-19 on specific prioritized health needs. So it's it's in its own section and also dispersed throughout. Hampden County had the highest total deaths and total cases in the region, both in terms of absolute numbers and also in terms of cases per 100,000. In other words, the per capita, and then deaths per 100,000. So we need to, remember and honor those losses. They're deep. More than 2,000 deaths as of earlier this year, and more than 127,000 cases in Hampden County alone. Obviously, it affected all these other issues, and we'll be talking a little bit more about that when we get to those particular issue areas. So we tried to align the presentations to what your community teams have been, and we know that you may shift focus going forward, but we wanted to at least represent based on the teams that you have currently. So in terms of youth mental health, the CES, the Collaborative for Educational Services, did extensive qualitative data collection, dozens of key informant interviews throughout Hampden County, primarily with youth development folks and with youth mental health providers. We also collaborated with the Youth Mental Health Coalition of Springfield, and they were already doing focus groups with youth and with parents and caregivers about other topics, but we were able to access that data and where appropriate, weave it in. So we were very grateful for that. With this topic and with all the topics that had major focus in the CHNA, we really tried to devote some context setting at the beginning to exactly the things reflected in the value proposition. How has the history, the legacy of white supremacy and structural racism and poverty affected these issues? And so we really like this graphic that kind of talks about the need to dig deeper when looking at mental health. So we have a lot of data from the COVID Community Impact Survey that was done in 2020 statewide, and Victoria has been crunching lots of numbers over the last year and slicing and dicing that data, and still doing that as the regional provider of that data. So if you are looking for ways to use that data to support your case making or for whatever purpose to better understand how certain populations were affected early on in the pandemic, it's not too late to get support to do that. 45% of youth in that survey reported feeling sad or hopeless every day for 2 weeks or more in the past 12 months. And close to 20% or 1 in 5 youth experienced 3 or more PTSD-like reactions to the pandemic. And that rate was significantly higher for youth with disabilities, LGBTQIA+ youth, and also those who were female and living in rural areas. And then the youth health survey had very similar data, almost identical. Actually, this is the same, sorry, this is the same community impact survey data. This is the Springfield Youth Survey data. So the Springfield Public Schools data is much more inclusive of youth of color because Springfield Public Schools are majority youth of color, whereas the statewide survey did not reach as many youth of color. And there we saw 4 in 10, 40% of 8th graders feeling sad or hopeless for 2 weeks or more. And also seeing greater disparities with female, LGBTQIA, and youth in terms of greater suffering around mental health. There's a lot of slides about the qualitative data collection that CES did. I think in the interest of time, I want to kind of jump ahead to what they found, their conclusions. They found a series of tensions So nothing was clear cut in terms of, yes, no, it was more a yes and. So social media is kind of a double-edged sword. It helps people feel connected and supported, but it also affects their mental health, and girls in particular. There's a lot of data showing that they experience a lot of emotional harm from social media. Schools can be both a place to assess and support youth, because they are there every day, especially now that they're back in person, but also these can be oppressive systems where certain youth actually experience discrimination and harm and don't feel supported. The role of healthcare services can be positive in both diagnosis and providing treatment. But as we know, there's a shortage of culturally humble, culturally diverse mental health providers for youth. The stigma is somewhat abating with youth. They're becoming more comfortable with talking about mental health, and social media has helped with that. But there still is some stigma and reluctance to share with parents for fear that they will not understand or will say, you're not crazy, or make judgments about mental health, and also their own peers. So sometimes it's safe to share with peers, and sometimes it backfires, and it gets out, it gets around, and then there's some regret there. I think we kind of talked about the role of parents. It can be positive, but also parents can be in denial. Then in terms of service design, there's ways in which it could be more youth-centered and less kind of centered around organizations. So that was some of the findings around the youth mental health. Some of the gaps that were identified, the need for community development, mentoring. I know that that's something that you all have been working on. It continues to be a need. More youth programming, youth development opportunities, and more school-based resources. On the clinical side, there's a real shortage of acute care capacity. So youth are ending up in emergency rooms and just sitting there waiting for a place to go. As we talked about, culturally competent providers, just more access to therapy, even just regular old therapy. There's just such a shortage, and being able to sustain those therapeutic relationships. Some assets, youth assets, there's a strong desire for youth to connect to peers, to adults. There's strong peer support systems. There are family supports. There's comfort in talking about mental health. They want to be successful. They want to be engaged. They're resourceful, and they're resilient. And then finally, community assets and models to build on. Youth centers, youth-centered programming, peer support groups, adult youth mentoring programs, peer-to-peer mentoring programs, school-based referral systems, faith and community centers, culturally competent care where it is being provided already. There's some enhanced training happening for primary care and pediatric providers, so being able to build on that. The sort of networks and coalitions that are in place, examples of integrated community-based services. And then there's a plan to increase access to acute care or crisis beds. So that's a lot on youth mental health in a very short amount of time. And since it is such a big regional focus area, wanted to just take a minute and sort of get reactions, see if there's things that people want to lift up or emphasize, or ask about before we go on. Anything people want to, probably nothing terribly surprising there, but if there's anything that stood out for you that you want to lift up.
I just want to say briefly, Jared from the Holyoke Farmers Market, briefly, the importance of after-school programs on the youth. I think I'm kind of like youth centers, youth-centered programming, and how that might help on like mental health. Speaking as probably I think I might be one of the youngest people in the room. That's probably helped my journey, and as well as my colleagues' journeys. My friends, is after school program is probably having something to do after, school and feeling welcomed, feeling safe, and all these other things, and having like counseling at those after school programs.
Great point. And I think even though they weren't specifically named, they're part of that whole youth development, community-based supports that are happening.
Did you have a sense of if there's enough resources and assets to meet the need? Like just
definitely not.
Yeah, that's what I thought. But and when you say there's plans to increase accessible youth acute care, like how should we understand that in the community? Does that mean somebody's going to add beds or somebody's building another facility or?
Yeah, I believe Baystate is increasing their beds. And I think that, by the way, there is a plan sort of in the works to do in January to do an event that will involve we're going to release a freestanding report just on youth mental health over the next months. And so the idea is to really engage youth between now and then and kind of both ground truthing what we heard and talking about solutions with them, trying to support their leadership in coming up with next steps, and then having an event that will allow hospitals and policy advocates and policymakers to get together and talk about, what can be done in the region. So, I think that'll be a good place to hear more from the hospitals about what they are doing and, where community partners can step up and help. And where more resources, I know there's a lot going on at the state level and coming down the pike that I won't pretend to know the details of around youth mental health or mental health broadly. So
I have two quick questions, Lisa. Maybe I missed this. How are we defining youth? Like what's the age cap? And then I'm wondering, maybe people could just put their hands up. How many of us work directly with youth? Like, do we have enough people in the CHIP who represent the resources that these young people need?
Great question. So the coalition decided to focus on age 12 to 24. But the honest truth is that most of the data is related to in-school youth, 12 to 18, say. It was hard to get a lot of data about young adults. There's not a systematic collection of data for youth who are either no longer in school, in high school, no longer in public schools. And even if they are in community college or college, there's not a lot of data collected at the local level about their mental health. So do folks want to do a show of hands for Liz around who is working with youth or on youth issues? We have a few hands going up. Marissa, and then Robert. Or are you just putting hands up to say you're engaging in? Okay, great. If anyone has their hand up to make a comment, just feel free to go off mute. Thank you for raising your hands to let us know who's working on these issues. Great. All right, well, I'm gonna turn the mic over to Victoria. I will keep managing the slide deck and try to monitor the chat, but Victoria will take over the presentation.
Thanks, Becky. Hello, everyone. I'm Victoria Ramos. I'm Lisa's colleague at the Public Health Institute. It's nice to see a lot of familiar faces. I worked with Becky and all of you a couple of years ago. It feels like it wasn't too long ago, working on community teams 2 and 5, which are the mental health and behavioral health, and also our violence and trauma team. So it's nice to see you all again. So with that being said, I'm going to walk you all through some indicators that may be relevant to you all in your work as you continue to make progress on these issues in our community. And I'm going to start us off with community team 2. So we wanted to share some findings around what we found around substance use and mental health. And with this slide, we just want to acknowledge that we're sharing numbers, but we know that there's lives attached to these data points, and just want to acknowledge and give space to folks to walk away if they don't want to hear these numbers, and to take space for themselves as we go through these. So with opioid use, just wanted to share that we acknowledge there's been tons of work around opioid prevention, especially with our community team too, in terms of addressing needs to how do we prevent these tragic deaths. But since 2017, we've seen a drastic rise in opioid related overdose in our county specifically. It's been the highest in the county compared to the state, in the highest rate of emergency medical calls for opioid overdoses in the state. So just want to acknowledge that. Next slide, Lisa. In terms of mental health, we've seen also a rise in mental health related emergency department visits in our county. It's the second highest rate in our region. We know that there's been a shortage in mental health providers, so that's something that potentially could be addressed, or is something that is currently ongoing work in terms of how do we get more mental health providers in our region. And we know with COVID-19, there's been a great exacerbation in mental health related issues, and a very high need in terms of resources to address these. Okay. That's a great question, Liz, in terms of Springfield residents. So actually, we don't know, and maybe there's some folks from community team 2 can share more about how these opioid related overdoses are captured in our systems and the challenges of figuring out where these folks are from. I don't know if anyone wants to chime in. But really, there's no way to identify if they're from Springfield originally, or if these overdoses just happened in our region and were reported because of that's where they found them.
It's a little bit of both. And I'm sorry, this is Brenda Evans. The City of Springfield Department of Health and Human Services was doing that type of tracking, because there is a mechanism in place of where people are actually overdosing. But quite frankly, I think a lot of people that are overdosing, that's included in these numbers, are not residents of Springfield. They just come here to buy their drugs and get high and go home. But Justin Chelman from the health department would probably be the person to have that information.
Thanks, Brenda.
I wasn't thinking too much of people who come and have a drug experience that results in death. In my neighborhood, I live in Mason Square in the Midnight area. We have quite a bit of dealing that happens on the edge of my neighborhood in the Bay Street neighborhood. And so I've given Narcan 5 times in the last 9 months, I think. The police, and they were all white people who I know don't live in my neighborhood, because I know everybody nearly who lives in my neighborhood. And the police say that we have an influx of young people from the hill towns who come here seeking treatment and then don't get into it right away, here and Holyoke, but here more than Holyoke, and then are living either on the streets or in shelters here. and that they are a large part of the population who's dying, and they report them as Springfield deaths, and the other communities really like that because it looks like their death rates are lower. I don't know how you could parse that out, but I just think it's an important thing to lift up. Not that, you know, these are young guys, and I don't care if they look like JR, if they look like Sarah, they're young women too. They're still young people, and I want to care about them. I do care about them as deeply as I care about Black and brown folks, but I'm just tired of us sort of being labeled as this drug center.
Thanks, Liz, for lifting that up. Yeah. Okay. And I think that's a great point in terms of like, how do you take this information moving forward and figuring out where those gaps are of how do we address these issues as we move forward in the work from understanding the problem to actually implementing actions. So thank you. Okay, so in terms of primary and preventative care during the pandemic, we saw that primary care shortages were also exacerbated. We know that a lot of these issues are ongoing and have been going on for years, but we know that the pandemic just kind of added another layer to these issues in our community. Hampden County health officials that were interviewed during the CHNA process, a third of them lifted this up as a major issue in their community that needs to be addressed. And some of the ongoing issues that made this issue worse is obviously there's a greater pressure on the healthcare system. We're seeing more folks who are in dire need of services and supports, and there's not a lot of support for providers themselves. So we're trying to think about how can we support providers and get more providers into the system that reflect the communities themselves. We don't just want more providers, but people that can actually meet the needs in our community and reflect our community and just promote all the needs that are needed in terms of representation, from language to race and all of these things. Okay. So one of the things that arose and was really becoming more prevalent during the pandemic was telehealth. So how do we pivot to telehealth to kind of meet the needs outside of patients coming directly into the office? We know with the pandemic, it was difficult for folks to come in for regular routine care. So telehealth was really a great resource. And there was a lot of advocacy. We know also in community team 2 around increasing access to telehealth for mental health services. So just want to acknowledge that. But it really was a great resource to help patients get the care they need during this unusual time. But we want to also acknowledge that digital equity is also something that needs to be happening hand in hand with this work in terms of getting folks access to the tools they need to access telehealth, whether that be technology, internet access, and all of these things. So in the report, you'll find more information about current digital equity efforts that are going on in Hampden County, and you could read more about that there. And then lastly, addressing provider shortages. There's been a lot of emphasis in Hampden County in terms of workforce development. How do we get resources out there to meet the needs of all of the job openings in our region? So as part of Baystate's Better Together program, they have this program ongoing with STIC and Westfield State University, which is a dual enrollment program to get more students trained on an RN to BSN track. To get them directly into the workforce. And that's just one project. There's a ton of other workforce development efforts that are going on in our region that not only are driven by the health systems themselves, but also at the state level through advocacy.
Yeah, and thank you, Sasha, for lifting up the telehealth access resources. So that's great to know.
Thank you. Okay. Next, we want to address just the impacts of COVID in terms of being able to meet basic needs. We know that there's so many factors that go in terms of someone's ability to live an active and healthy life related to like the work that's going on Community Team 4. And beginning with that, we just want to acknowledge how important income is as a factor to be able to attain health. So during the pandemic, we saw this great spike in unemployment that we haven't totally recovered from, that really drives someone's ability to get the things they need and to live a basic life. So want to address that as a key point moving forward. Next slide, Lisa. Oh, thanks for pointing that out. Okay. So one of the key issues that arose, that came up in the report, is just a massive need for housing. We see that there's a great shortfall in the availability of housing for people in Hampden County. And it's not only in terms of like access to housing itself, but just all the issues in terms of affordability of housing in the region. So we see that, again, income is an important issue, but also just issues with just rising costs overall in our region. And then when it comes to food insecurity, we see that in Hampden County, during the pandemic specifically, we saw a huge rise in food insecurity that we haven't totally recovered from. We know that there was a ton of effort to get folks access to food during the pandemic through our food pantry system and all of these other resources that were kind of pumped into our region, but it hasn't fully addressed the issue of food insecurity in Hampden County. So there's still work to be done. And then lastly, we want to talk about violence and trauma. And before we provide any data, we just want to give folks, again, an opportunity to take care of themselves as they need to when presented information about violence. So in the reports, these two issues around domestic violence and gun violence arose as primary issues. We know that in Hampden County, there were over 3,000 restraining and harassment orders filed during the pandemic, and that housing and mental health were some of the biggest challenges for survivors during the pandemic. And then we also know that in Hampden County, there was the highest gun death rate in Massachusetts overall, and Black and Latino residents were disproportionately impacted by these deaths. Any questions, comments? I know we went through that pretty fast.
Yeah, Victoria, you did an amazing job of getting through all that. And, you know, that's part of the challenge of the CHNAs, that it is just so much data. And so really encourage folks to, once you look at the full reports, you know, focus in on the things that matter most to you, that are most relevant to your organization. Hopefully it should be pretty easy from the table of contents and the way the reports are laid out to find those sections. But obviously we are resources if you need help just sort of finding what you're looking for, or understanding what the data is telling us.
Thank you, Lisa and Victoria. And that's amazing you guys got through that. That's really great. But we do have some time for some more questions, if there's any other questions. Otherwise, we can break into breakout rooms, and I don't see everyone's hands. So, oh, Kathy, do you want to chime in about Holyoke? Thanks, I just saw you.
Yeah, thank you. So everyone's good with questions?
I just have one comment that I really appreciate this. It's really hard. It's really hard information. So everybody should take a deep breath. But I think what I'm most feeling grateful about, if you can feel grateful when you hear that kind of stuff, is the support, the earlier statements and work that you all have done around illuminating racial equity. Like, I don't remember a time when we were given hard data and it was acknowledged that there could be people in the audience who might be impacted by this information. Just the moment that you took to say, this is some stuff that's coming and you might need to step away, I think that's heavily informed by people like Sasha and Victoria and Brenda and everybody else, and people like Sharon Ho Smith who have been having the experience of living with and raising and working in communities of color. That didn't happen the last time we looked at data. It's never happened for me in another meeting. These numbers are horrible, but the care and the language that is being used in sharing this information is why I'm so adamant that we have to look at the root cause, why it's been so important to me to see people who look like me and my son and our community working on this. And even as we're getting all this really horrific information, I want those of us who've been around the CHIP a longer period of time, like Benjamin and Risa and others, to look at the screen of those people that we can see. Like, we weren't representative like we are now some years ago. And I think that speaks to the really good work that the Health Equity Network and the CHIP is doing to see Black and brown men, to see non-straight people, to see Latinx people sharing this data and having the capacity to help us understand it is a really powerful thing for me as an older, very specifically Black woman, but as an older woman of color who's been working in community most of my adult life. Like, for the younger people and for the younger white people, you may not understand how important this is, but it's a big win. These numbers will take a long time for us to change. I just want to make sure that we celebrate the young people at this table, the white people who can hold space with us and not be freaked out and want to turn off their screen or run away, of whatever the age they are. So I'll pick two that I know, Zoe on one end and Kathy Anderson on the other. This says a lot about who our community is, and the space that you make for people like me who have to ask a lot of hard questions. This is a profound thing, and this is the thing that will lead to us getting to where we want to be with these numbers. So we're all feeling maybe a little disheartened, and I want us to be heartened by, we're starting to tell the truth about what's happening. And that's a really, really good thing. So all of you who were involved in putting this together, but especially I want to celebrate the young people of color, because they are still in majority right rooms, still out trying to ask questions, still not leading and driving the work in the way that they can and should. And I want to say to those who I know, Benjamin and Sasha and Victoria, that I feel worried, and Tiffany, all the time about us, like, where are we going as a people, like all people, but especially people of color. And it feels worse to me. I turned 60 this year, and there are some things that are amazing and some things that I'm like, shit, we're still in the same place. Except that we're not, because you were all here, and I've watched Nicole from afar sort of grow up in this work. And it makes it different who's leading the work, whether they're at the agency level or whether they're, working on wonky policy like I do. I'm lucky because I get to be with kids in the afternoon. So I really want us to pay attention to the numbers, but also pay attention to what I see as the really good.
Well, thank you. That's my segue, I guess, Liz. I remember in 2019 when we were talking about this, Liz, and I remember having a conversation with you because we were just looking at each other, and I really felt what you were saying, and I took that to heart. Anyways, we have our own, Liz and I share our own story, but thank you for letting me have the time today. I would like to introduce Lisa Schechterly, who's the new Community Benefit Director at Holyoke Medical Center. I have retired. Tonight, we're presenting the CHNA to our Board of Directors. So I agreed to stay on to finish this process since we started it about a year ago, this last September. I've been part of the larger group, and I used all of the same questions that all of the others hospital use so that we can use regional data. Our time frame is a little different, though. As Becky mentioned earlier, our board is voting on this tonight, so I'm sharing with you all of the information. I'm just not showing you our report right now, in fairness to our board, but I'm happy to answer any questions. And Lisa, today is a handoff for me to Lisa, who will be staying on this group and going into the breakout sessions. When you break out, I'm going to break out and off and go join my grandchildren. So But I do want to say that it's amazing how much our report will mirror, Lisa, what you and Victoria talked about. We asked, as I said, we asked the same questions so that we could share the information regionally. I personally interviewed over 30 stakeholders from Holyoke, Chicopee, South Hadley, West Springfield, interviewed a number of community groups. Our Community Benefits Advisory Committee was extremely helpful in connecting us with people to interview, like the Holyoke Housing Authority. I interviewed residents of different places throughout the city that they lived at Holyoke Housing Authority properties. One Holyoke CDC offered us their table at Key Foods, and we used Nairobi, as you mentioned earlier. And we used that on 3 different occasions, and we gave incentives, $10 gift cards right back into the grocery store, so people could talk to us on their way in and buy groceries on their way out. I also interviewed the superintendent. He put together a couple of different groups of students from both Dean and the high school. I interviewed the LGBTQIA+ group from Enlace, and they helped me craft some of our questions for our survey. So I reached out to them prior to sending out the survey to make sure I had some meaningful questions and I were asking things the right way. So let's see what else. When we asked people to take a look at the issues we heard in 2019, because that was one of the questions, is how are these issues different or the same? Every single person felt all of those issues were still relevant, but one form of mental health or another would be brought up as most important. So everybody talked about mental health. When asked to take a look at the list of vulnerable populations we identified from 2019 to see if any have changed, all people said that the list was inclusive, but felt right now that youth and seniors were the most vulnerable, especially during and throughout the pandemic. We did put, Lisa, do you mind pulling up? We did put a sheet together here that this is really pretty much everything that we heard from the interviews. I also want to say I did share all of the interview documents with Lisa early on so that she could see what people were saying as well. But mental health was the top issue. Everybody talked about mental health, and we did break it out into mental health with all ages and mental health in children, because we did hear some different things from both groups. But the majority of people talked about long waiting lists and lack of providers, as you heard with the other CHNA. Social isolation was huge, anxiety, depression, suicide, and these are pretty much in order of how the importance of how we heard them. Gambling and gaming, gastrointestinal issues caused by anxiety, levels of trauma during COVID-19, stigma, and how to access the right provider. Under children, and I spoke with the counselor who oversees all the behavioral health folks in the schools through River Valley Counseling. I interviewed a number of folks from River Valley, but I did interview somebody that oversees all of the counselors in all of the schools we're in, and we're in all of the schools I mentioned. I mean, the communities I mentioned: Holyoke, Chicopee, South Hadley, East Hampton. They're pretty much all around here. And she talked about anger, anxiety, gaming, kids being showing tantrums and anger when being asked to not game anymore, or being punished from gaming because they did something. Education for parents around mental health, education for schools around mental health, and emotional resources beyond the school day, as someone talked about, after school programming. These were all things under children with mental health issues. We, just not to back up too much, but River Valley Counseling has started a trauma-informed community. We had her name's Porter, I can't remember her first name. She's like the specialist around trauma. She's out from Washington State, and she came out here a couple of years ago, and we did a conference on trauma-informed communities. And so River Valley had gotten a grant, I think from the city, And they have started to do training out in the community. So they've trained, they're training police, fire, teachers, counselors, and that has already started. So that's something that maybe some of the folks in this area might like to get more involved in or learn more about, because it's really a program that's going to be very helpful, especially in the schools. Substance use disorder was the second top issue that we heard. Drug use and other substances heightened during the pandemic. Overdoses, as Liz was talking about, increase in overdose, fentanyl misuse, increased alcohol use, and stigma. These were all issues that we heard under substance use disorder. We also heard a lot about poverty and housing and homelessness. And trauma informed. Okay, Brenda, we'll follow up after. So under housing and homelessness, I interviewed 4 boards of health, and each one of them told me that they're dealing with hoarding as a mental health issue. And one of the things they had said was, you know, they're there to protect the safety of residents. And they're trying to keep a resident safe by keeping them out of a home that's unsafe, but then they're putting them on the street, and they don't like doing that. And so, we're talking about doing some education around this, especially as a mental health issue. Homelessness is still an issue and remains one in all of the areas that I mentioned. And then code issues from chronic illness, from a chronic illness perspective. And we looked at asthma and other health conditions that are exacerbated by, you know, mold and mildew and other dust, just, you know, dirt in general that can exacerbate different health issues. Under chronic illness, it was diabetes, heart and asthma, and then weight issues, especially in children since the pandemic. And then food security is still definitely something. And that was, we have a community dinner that we do twice a month for people that, and during the pandemic, we had to go from in person to a drive up, and we give 120 meals out every single time. And it was amazing to me how many more senior citizens we saw than we did before. And, you know, we did, when in interviews, it was definitely something that was an access issue for seniors. And we did a lot of work around trying to get food to folks, Liz being part of that group, and Becky, trying to make sure that people are getting food and have access, because sometimes there was plenty of food, but it was getting the food to the people. Okay, let's see. I was trying to go through the questions that Becky sent ahead of time. These areas of focus were throughout all of the areas we serve. And then some root causes or things that we heard, systemic injustices that we identified. The LGBTQIA+ group talked about facing gender biases, assumptions of sexuality and gender, challenges in finding a mental health counselor or finding a doctor that knew what they were going through. Transportation is still a challenge, an access challenge for folks, mostly for getting to primary care, mental health, and dentist appointments. We asked people about their about residents feelings about discrimination, and almost out of the 500 people that filled out the survey, 103 people said they were discriminated against for sexual orientation. 88 people said race, ethnicity. 68 people said physical features. 62 people said social and economic status, and 34 people said for a disability they were discriminated against. We did ask some questions about racism. When we asked if people felt there was enough being done about racism in our community. In the communities we serve, almost 59% of those surveys said that there was not being done enough. And we did ask for some ideas. A lot of people talked about education, examining biases and where they originate from, training on biases, community conversations, integrated community projects. There was quite a few ideas that we're happy to share with folks on that. And then financial literacy of all ages was something of concern as well, as far as access and financial challenges. Lisa Ray Shechtely, did I forget anything?
I don't think so. I just wanted to add our service area is not quite as big as the previous report we saw, but it does include Hampden County and parts of Hampshire County. And then this report, after we meet with the board this afternoon, should be posted tomorrow on our Holyoke Medical Center, holyokehealth.com.
Questions?
I have a question.
Sure.
In regards to the gambling and gaming, do you expand on that in your report? Or is it just named?
No, it's just named, but I am waiting for some information on students in the schools that might give me more on that, if that's something you're interested in. And Lisa, any of the stuff that we get, we can share with you as well.
Not me personally, but I know a faculty researcher that would be, who actually is the Sigma project for the casinos.
Oh yeah. Yep.
She would be very, very, as a matter of fact, they're starting to go into that realm because of the sports betting.
Interesting.
Into that space.
Yep.
So thank you.
Yes, thank you. Yeah, please feel free to share my name if you'd like. So Lisa will take it from here, and not today, but literally take the report from here, and we'll be working on the implementation plan. As we said tonight, we're voting, our board is, we're bringing it to our board, and that's my true handoff, and I'll be fading into the sunset with my grandchildren, but advocating for all the things we're talking about, just in a different capacity. So it's been wonderful working with all of you, and I've learned quite a bit from each of you. And I know, I must say, Anna Marie Golden was extremely helpful when I first started back in 2018 or so, and brought me into this group. And it's been one of the best things to open my eyes and try to do the best we can for the communities that we serve. And I've worked with Lisa Ray Schechterly for probably 30 years of my career. And she's doing wonderfully. She is caught up to where I was, and I have no doubt she's going to do good things for the hospital. So good luck to all of you in the work that you do. And when you do your breakout, I'm going to break off. So bon voyage.
Thank you, Kathy. You will definitely be missed, and I have really big shoes to fill. So thank you.
You will definitely be missed. Damn grandchildren. I don't know why you want to spend more time with them than you do with us, but makes no sense at all.
Don't worry. I'm going to deliver some llama poop to you yet.
Anyway, I think that you have, sometimes we just go away, and you made Holyoke better. You made Hampden County better. You made me better. And you will be out of sight, but not out of mind.
Ditto right back.
Thanks. Thank you, Kathy and Lisa, for sharing all that information with us today. That's really, really helpful. So we're running a bit over, and I would just want to check in with everyone. Do you want to do breakout rooms, or do we want to have just a group discussion about sort of initial, I guess, initial reactions to all this data? It was a lot. And a lot to sort of process, but just in thinking about, where we go moving forward, and how to build on some of the great work that's being done already, but also address some of the sort of emerging needs that we haven't addressed in the past. Gail.
I just had a quick question. I'm, as I mentioned, most connected to the Baystate Wing CHNA, but absolutely with our alliance want to look at what's happening in Hampden County. We serve a number of towns there. I really appreciated one slide that was shown where things were broken down by cities. I really appreciate the inclusion of Palmer. And I guess I'm just wondering if in the report both Baystate, Mercy, others that are, think of those outlying towns in Hampden County. If there are other places where the CHNA, either reflects on those communities like Palmer, Munson, others, as part of thinking about Hampden County and the diverse areas that make up Hampden County.
That's a great question, Gail. I would say just kind of looking through the Baystate Medical Center report, it really depends on the data source. So I won't say that we did that extensively throughout the whole report. In some cases, like for example, we have a food insecurity map that breaks out by town for Hampden County. So it's not consistent. Obviously, in the wing report, we have a lot more data for those.
Sure. I appreciate any of those efforts. Sometimes in the smaller towns, the data is not there or the numbers are just too small. So I appreciate that, but it's also helpful for us to think about some of those Hampden County towns with respect to neighboring and other Hampden County areas, along with looking at other parts of the wing service area. So I appreciate that. Thanks.
Excellent point.
Lisa, where is that map that pulls out food insecurity by town in Hampden County? Where is that accessible to us?
It's already in the Mercy and Shriners reports, and it will be in all of the reports have a food insecurity map for their service area. So the ones for Hampden County will be in all three. So you can already see that online in the Mercy and Shriners reports. If you want, while the conversation is happening, I can try to pull it up and just share screens to show. And then the Baystate Medical Center report that's coming out at the end of this week also has the Hampden County food insecurity map.
Gotcha, thank you.
It seems that everybody wants to, I've seen some comments that people would prefer if we just continue this conversation as a group, Becky. So let's
Yeah,
do
that's
it.
great. So any initial reactions, feel free to raise your hand or just or speak out, and what are some, I guess, some reflection on what we've heard and where we should go moving forward. I think one thing that has been standing out to me a lot lately is the housing issue. And I know there are a lot of groups working on that, but it is, it's a really basic need. And I know homelessness is a huge issue in our region also. And is that something that, we should start to think about and look for some strategies.
Becky, do we have a person focused on housing or persons in the CHIP team? Or when you say focusing on it, what do you mean? I agree with you, but I wonder who we have, who's the expert, for lack of better language, like who's our person housing?
I don't know if we do right now, and that's part of the issue I think we've had is that, when we started to hone in on implementation work, we really, the community teams have been focused around specific strategies. So there may not be people involved now who maybe would be really helpful to have them involved. So I think that is a good question. But I guess, housing is sort of one of the root cause issues, but in terms of overall health concerns, sounds like mental health, youth mental health is a big one. Access to basic needs, which covers housing, transportation, basic economic security. Anything else? What are some basic, reflection? It's a little overwhelming. Um,
I think we need a prompt, Becky.
Well, the prompt for the breakout rooms was, based on your own experience in the communities you work with, what priorities do you think should be included in an updated CHIP? So have you heard, from the data, does that reflect your experience? For those of you working in community, what are priorities that you see going forward? And it may be the same ones that we've had.
Well, I can't talk about this, but I can lift it up as a need. So youth mental health is not my space, even though Guardian Community and the Food Policy Council both have a youth serving piece of our work. I worry that our capacity to respond to where kids are right now is not strong enough. We had 2 youth this past summer who I had a lot of direct responsibility with the youth because of staff transitions. 2 youth tried to harm themselves. 1 youth asked me to call crisis while he was at GTC. That experience, I was struck by how the other youth kicked in. They were able to provide peer support, just like half of them stopped working and came to surround this kid and said, don't be embarrassed. I want to call for help sometimes. I was blown away by their care and their knowledge. And then it hit me that they can show up this way because some of them have themselves been through this. And it was even though this was a conference on hunger and nutrition, there wasn't a group that I wasn't a part of or wasn't a person that I spoke to from across the country who raised it as an issue. I've always known it was a big issue because I've known Sharon for a while and worked with teen pregnant and parenting adolescents with PHI, but it feels just experientially on the street like it's just increased. And I feel crazy, so I'm not surprised that I realize it's bad language. But I really feel like, am I losing it some days? That's why I had to turn off the screen and just be really still reading that data because it validates what I see. So what's happening with kids? And I also recognize that the kid who was saying he needed to talk to someone at crisis, it was also the day that kids we give every kid a fresh food card so they can shop in the store. And that was the day the food's turned over. And his concern was, am I going to still get food from my family? So I don't know, I don't even know how layered this all is, but then I think about young parents, Nicole. Some of them are still adolescents and they're struggling with taking care of other children, their own. And I don't know how they're navigating through. And food obviously is an increasingly high priority. The recession has made it even worse. I have more people just asking if we have food that they can have because one woman told me she sold her food stamps to get the money to pay her light bill. And that's why she couldn't use her HIP benefit because she didn't have any SNAP left. It's just so complex. And she was very young. And there was a part of me that applauded her resourcefulness because she needed to keep her lights on. And she had to make a choice, those choices we talk about. So I wonder if that helps start, what are other people seeing?
There's, I want to acknowledge Marissa. She put in the chat, transportation to and from food distribution sites. I'm finding that people are now more aware of HIP.
Yeah,
Go
so
ahead,
I
Marissa.
mean, it's great now. I'm telling people about HIP and I'm not even able to finish my sentence because they already know about it, which is great. But the conversation ends when they say they can't get there. Or, there aren't enough spots in their area or the times don't work for them. So, it feels like a dead end, but I know there's work being done around it, but I thought it would be worth talking to the group as a whole because I know we talk about it in our domain, but since we're staying as a group, I wanted to mention that. What were you gonna add to that, Brenda?
No, I just wanted to make sure your comment got acknowledged.
Oh, thank you.
And there's another one in the chat too.
Yeah, I see that. Sharon has her hand up too. Go ahead, Sharon.
Okay, but I will agree with Marlene's, the housing piece. We have some young adult housing programs, and we're definitely seeing a lot of calls to our 24-hour line for the 18 to 24-year-olds having housing instability. But I did want to piggyback on what Liz was saying about the youth mental health. We have a photo voice youth gambling prevention project, and in the spring, one of the groups that we ran, at the end, they come up with a call to action, and one of the groups came up with, as their call to action for the community, more informal mental health supports among trusted community members, as like an ask that they were having, because they were seeing so much need for mental health support and feeling like it wasn't very accessible. They wanted it to be as accessible as sort of the guidance counselor is in school. You can walk into their office. They wanted places within the community where they could seek out trusted adults when they were having mental health issues. So I just thought that that really sort of dovetails with what was said before. And I wanted to raise their voices because it was a small group, and because of pandemic restrictions, we weren't able to do as big a sort of an exhibition of their photos as we normally would. So just wanted to share that.
Thanks, Sharon. That also kind of mirrors what Kathy was saying about a community mental health trainings, which sounded really interesting. Gail.
Sorry if I'm talking too much.
I wonder if Sharon would know better, and I don't know who else works in the mental health, emotional health, behavioral health care field, but like last night, President Biden in a meeting that wasn't recorded, charged us with thinking about, if money were no issue, what would be the thing you would most immediately want, and write down the 3 things that first came to mind. And I, just because of my orientation to it, and I know Brenda, I immediately thought community health worker, like embedded at GTC. But maybe what I want, Sharon, is I want 2 things. In the same way that the Food Policy Council and GTC are continuing to train people who touch people to talk about HIP, is there some training that could be developed, supported by the CHIP, that would help us be able to identify, those of us who don't work in that space, identify folks at risk and build our own capacity to know who to make referral to. My kids told me who to call when this particular young man was saying, I need help, I need to talk to someone in crisis. I really thought, do I call you or do I call Lisa Holland? Because you're mine. But the kids told me who to call. But I should know, and my whole staff should know, right? And so if you could teach us, I don't know how much can be taught in a reasonable period of time. I'm not trying to turn into a counselor or have anybody on my team think that they are a counselor, but I absolutely, if we see a kid walking like this, I want us to have the resource to grab them as they walk away and say, are you okay? Do you need a minute, or should we call someone? Or is that a thing that could happen that we could do for each other? Really, that you could do for all of us? Sharon, that's a direct question. Or anybody else who works in that space. That's a direct question.
So I was going to say there are some programs out there like Youth Mental Health First Aid that have been, there's been some of it done in the community, but not probably as much as may be needed. So I'm sure there are other programs. So I know only a limited amount about that.
It also sort of reminds me of the work that Isabel was doing, Isabel Garcia, on the key work with the, people who have direct contact with young people. Gail, you've had your hand up.
Thanks. I just wanted to relay a brief anecdote from a training I was at yesterday that just really has stuck with me in terms of some of the ways that our youth and young people are having to manage really serious, stressful issues. a school nurse who was at one of the school districts in the small towns of Eastern Hampshire, Hampden County and Western Worcester County, was at a Narcan training because she's going to do Narcan trainings for high school students who are very worried about family members who might be opioid users, and therefore another source, as if young people don't have enough stress with social and school and neighborhood and other issues, but they are extraordinarily worried about friends and family and want to know more about how they might be in a position to use naloxone to rescue someone from an opioid overdose. And that just really stayed with me as another way that maybe those of us working in the substance use space who are trying to help more community members be aware of Narcan and how to use it, how to get it, make it more normalized, to not forget about youth and young people, because they may have those fears and worries about someone they care about as well.
Yeah. Okay, so anyone else have comments or suggestions? Not, we'll talk about next steps. I want to make sure you all know about the implicit bias training, and I'll put that in the chat. There's a couple, let's see. There's a flyer and a training description, and again, there's two trainings, one in person on the 27th and the one on November 3rd. Will either be in training, will be in person or on Zoom, depending on how many people register. We will be sending out a newsletter soon with dates for community team meetings and continuing to have these discussions about priorities for the CHIP moving forward. And we're also going to start to think about, ways to engage community members further, maybe visiting other coalitions. And we also have stipends available for people to attend meetings if they want to do that and are not otherwise compensated. So, any other closing thoughts? Really appreciate everyone for being here.
So Becky, what's our next step? Is it to determine if we're sticking with what we're working on, or are we adding something, or did I hear you sort of ask that as a question?
Yeah, it's really looking again at what are the emerging health priorities, and are the community teams, how can we articulate goals, objectives, and then strategies to address those goals. Some of them may be what we're already working on, but just to sort of hone in on priorities for the next 3 years and develop action plans so that we can seek funding to do this work. But we're also, we want to make sure that we're recognizing work that's being done currently. So looking at what's always already happening, what could be built on, and really where we can sort of align the work that's happening throughout the region. And try not to, I'd like to be more oriented around not being in our specific community teams. How can we there's a lot of overlap in youth mental health is a big one. I think each of the community teams is doing something around that involving youth. So how can we, build strategies that address specific health outcomes for everyone. So, all right. Well, thank you, everyone. And we'll send out notes and the recording of the meeting, and also links to the CHNAs, which should be available tomorrow, I believe, on the website, the Baystate website. And hope to see you all at community team meetings. And then we'll meet again, it's probably in December. So you.
Becky, can you stay on for just a second?
Sure.